to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Dr. Debbie Steele-Moore to the program.
Thank you.
Thanks for coming in.
Sure.
You are an optometrist and you have a practice here in Salisbury, and you're here to talk about the topic of vision loss, which is a very important topic.
Absolutely.
With many causes and many implications. But first things first, tell us a little bit about the numbers. What are the statistics about how prevalent vision loss is?
It's very prevalent. You probably hear mostly about macular degeneration. It affects number one is over age 65. Diabetic retinopathy is another vision loss, unfortunately, that affects under 50. It's the number one cause of legally blind under 50. Cataracts, there is vision loss with that, but it is treatable. Glaucoma, same thing. There's quite a few with glaucoma, but it's treatable as well.
I know I read that blindness or low vision affects 1 in 28 Americans greater than 40 years old. That's pretty striking.
It is. Absolutely. Approximately over 6 million have vision loss in the United States.
So this is a problem, and I know before we get into the different causes, and of course you brought some gadgets and devices to help people, let's talk about why it's such a problem or how it impacts daily life.
The biggest problem is lack of independence. Unfortunately, when patients have vision loss, they lose the ability to drive, they lose the ability to do things around the house, even cooking, reading their mail, separating their medications, then going to the store, not able to read the price tags or labels, or going out to eat, reading the menu.
Right. I know the two that strike me as the most dangerous are driving and obviously not doing so if you're not safe. And then the medication errors and things, if they're unable to read the bottles. And of course, I think most people really revere their vision, and I can imagine it's quite anxiety producing, can even lead to depression.
Absolutely, because unfortunately some of these conditions can be overnight. Some are gradual, so they have some more time to deal with it. Family can be very supportive of it, but unfortunately most of my patients, I don't want to bother my family. I don't want them to come over every day and do my medications. And then that just leads into more depression because they feel like they're a burden on their family too.
Become isolated to some degree.
Mm-hmm.
And what about, I imagine, increased risk for falls and fractures, which is particularly problematic in the older population?
Absolutely, and it can be for any population too, because monocular patients, if they lose their vision in one eye from glaucoma but still have great vision in the other eye, their depth perception is off, so stairs, walking even down ramps or potholes on the street, it's definitely a problem. There is something called orientation and mobility instruction that is offered by occupational therapists to help them learn with dealing with vision loss and walking, letting them know how many footsteps to the stairs, using canes and walkers. Most people will get those things but not really think about they need to be fitted for those type of devices to help them to walk. So that's where the occupational therapy is important as well.
Okay. Well, before we get into some of the gadgets you brought, let's first talk about, you mentioned 4 major causes. Let's just go through each one and give a brief overview of what the problem is in terms of consequences and so forth. So let's start with the most common one is macular degeneration.
Macular degeneration is a central vision loss. And so you can still use periphery, so patients can see with their side vision, but not centrally. So your face would be very blurred or almost absent in someone who has macular degeneration. Unfortunately, it's 50% likely for people to develop it from their parents. And if they smoke, 75% more likely to develop it too. The other conditions are diabetic retinopathy. Unfortunately, with uncontrolled diabetes, and it can be either type 1 or type 2, insulin dependent or non, they're still unfortunately around the age, about having it between 10 to 15 years is when they start to notice some retinopathy problems, or especially if it's uncontrolled from the beginning.
I was going to say, can it improve if you're compliant with your diet and your medications and so forth?
But there is also treatments needed too,
Right.
laser treatments or injection treatments, and that holds true for macular degeneration.
I was going to say, aren't there some injectables that medications you can give to help with macular degeneration now?
That is true. The dry form is more regulated by vitamin supplementation, but the wet form is treated by the injections. Diabetic retinopathy and macular degeneration do affect mainly the central part of your vision, so they have very similar treatment plans.
Okay. And then the next one is glaucoma.
Glaucoma is where it goes opposite. You are affected with your peripheral vision. So patients can still see centrally, but they're bumping into walls or they're missing the stairs because they can't see the peripheral. And then when you become legally blind from glaucoma, it's less than 20 degrees, which is about the size of a quarter that you're looking through. And unfortunately, glaucoma can cause blindness where you have no light perception, whereas macular degeneration, it does cause you to be legally blind, not being able to see the big E on the chart, but it never makes you go dark. So a lot of times people are they are actually more excited to have macular as opposed to the glaucoma because they know they're not going to ever go dark in their vision.
Now with glaucoma, I know there's different forms, and some can be very acute, and then the other form is more of a slow vision loss that they can use eye drops for and such as a treatment.
So glaucoma is basically defined as having a high intraocular pressure, and there's surgery and eye drops that can bring that pressure down. If the pressure is maintained under the target, then they won't have vision loss, and that's the importance of going to your eye doctor. And there is no signs or symptoms of glaucoma until it's too late, because we cannot regain your vision. The drops are actually preventing you from loss of vision.
So that's why it's important to see an eye doctor
Exactly.
at least
Annually.
every year and get your pressures checked.
That's correct.
And of course, the last one is cataracts. And I think most people know this is a correctable thing, but still, tell us about what cataracts are.
So cataracts can actually, it's become almost like compared to getting braces on, for the younger child. All the older patients unfortunately develop cataracts. Everybody does. Some surgery, some do not. And unfortunately, some patients can't have surgery, whether it's their systemic conditions that's holding them back, or they're already one eye blind from glaucoma, and it's a pretty high risk to have surgery to the other eye. So the medical or conventional treatment, once again, cannot work for them, so that's where the devices come in to help them more. And it can be as simple as just increasing your lighting within the home.
For many people, it's corrected with cataract removal.
It is.
And of course, what does cataracts gives you a different appearance too, right?
Right. I try to explain it as you're looking through a dirty window. And that's probably the best scenario because it turns whites into yellows. People don't realize when they come out from surgery and they say, wow, I can see, and the colors are so bright and vibrant. That's what they miss majorly with the cataracts.
Took some Windex to that window.
Exactly.
So before we get to looking at some of the devices that you brought, tell us a little bit about the referral and evaluation process for the low vision services.
Sure. Most patients going to an ophthalmologist or retinal specialist if they have macular degeneration or glaucoma or diabetic retinopathy, and they are treated medically up to a certain point until their vision is stable. Then the doctors will refer them because there's no medical treatment left or conventional treatment such as eyeglasses to help them. So then they come to our office for about a 2 to 3 hour evaluation where we go through everything that they're having troubles with within their home or even outside of the home. And then we show them the devices that will help with those goals. And then after we show them the devices with the goals, then we try to get the devices for them. Unfortunately, Medicare doesn't cover the devices. So we try support groups such as the state's DOORS is Department of Rehabilitation. The Lions Club does help with the devices as well. Or there's some private insurance companies, but a lot of patients do self-pay. They're not paying for eyeglasses anymore, so they're paying for the things that do work for them. So then they contribute that money towards the devices. But we're there definitely to show everything that's possible for them and then try to help them to obtain them, because most of the patients I see are on a fixed income for them. But there is insurance, there is supportive groups that we do get them in contact
Seems
with.
like you can always find money if you look hard
Right,
enough.
exactly. Yes, that's true.
So that's good news, though, that you can try to make something work for somebody. And I guess it is very much dependent on their current lifestyle and what's important to that individual.
Right. Their main goals. We try to find out what their main goals are. For example, would you like me to start to show you some?
Sure.
Okay. So the main goals we were kind of talking about before, these are magnifiers, and they're handheld. They're very portable. This one slides in and out.
So you can keep that easily
Yes.
in your purse or wallet.
Shirt pocket for men, and slide pocket for the women. They can use it at the stores for price tags, labels, menus. They both have lights to them. This one is great for the thermostat, appliance styles, medication labels. This one's preferred most of the time. Even mail. Patients will read their mail with the device.
So these take the place of reading glasses for most
Correct.
of us when we reach a certain age.
That's very true. Because these can range in power from 3 times up to 20 times. 3 times in power is approximately like everyone sees an over-the-counter that's a 250 or a 3. The 3X is actually like a plus 12. So to put it in numbers, kind of correlating. Now, as you get higher in those numbers to 3 times, 4 times, the size of the magnifier gets smaller. So as you go into the need for 9 times or 12 times in power in order for you to read the newspaper, this is an electronic magnifier that gives a 7-inch screen to allow them to move it back and forth to read. So that's kind of a nice thing that they've developed with technology. So the handheld magnifiers run $100 to $200. This one runs around $600. I know, and I sell eyeglasses as well. I know they run about the same. So I always try to say, take in mind, you're not purchasing eyeglasses anymore, but this is actually going to allow you to see. And this one actually has 5, 7, 9, and 12, as opposed to this is only a 3X magnifier.
Okay.
So you're only getting 1 strength here where you're actually getting 4 strengths
So that
there.
one's more flexible in terms
Yes,
of...
it has definitely more tools. We can change the background, so people have trouble seeing blue writing on a yellow background. So you can change that to be black and white. If they need to see a credit card and take that to the phone and order something, or a catalog picture, there's a freeze feature on this button, on this magnifier too. So there's so many more things that this one can do as opposed to a task magnifier that can only do a couple things for them.
So you are getting more for your money with that device.
Absolutely, absolutely. Now, as for watching television, which was one thing that we had talked about that a lot of people do miss because they are, unfortunately, some bed-bound, chair-bound. These are telescopes that people will actually put on to their face, and they do dial in and out, focus in for each eye, and then it brings you closer to me. So instead of me coming closer to you or coming closer to the television,
You turn the
put
dial.
you put these on, and you'll be able to see.
And that way, if someone has different vision in each eye, they can customize it with the dialing.
Correct.
Nice.
And then as technology once again improves, this is our newest device, which is called the New Eyes. And the New Eyes,
I mean, it's like virtual reality.
it is actually, they're actually calling it adaptable prosthetic device. And that's where the insurance companies are covering it, because it is considered prosthetic for patients.
So they will cover that?
A lot of Blue Cross Blue Shield at this point in time is covering it, not Medicare. So there is some insurances that are helping. But this device right here is like a computer on instead of a pair of glasses. So it will match with your phone. It actually will talk back to you. So it puts the reading script in here. You can look at anything and it will dial into the magnification, whether far away or close. It does have updates that are coming that will be called Be My Eyes, and you actually can program into a volunteer that will see what you're seeing, and they will walk you through the store. They will walk you through in your home. It does have GPS already involved with it. So it's
I can't
just like
imagine how much that costs, though.
So this one is running around $6,000.
Okay.
It comes with updates for the rest of life. It was actually made in the military to fly drones. And not only is it helping with patients for vision loss, because they took all that other programming out, but surgeons that need to look at an MRI, the MRI comes up into the screen while they're actually working. So it's branching off into the medical field as well.
Wow.
So, but we, myself and Johns Hopkins are the only ones on the East Coast that have this right now. So we've been definitely showing it.
So do people come to you for a low vision evaluation or low vision services, or you're saying they also call it low vision rehabilitation
That's exactly
visit,
what
and you see which device suits them best?
Correct. What we do is once we first talk to them about what their main goals are, and then we go down the list, because I need to make it by prescription. So someone who has 20/40 to 20/70 vision, which we actually call the early stages of low vision, they can get away with a 2x or a 3x. Patients that have macular degeneration or diabetic retinopathy, which are 2200 or above, which is legally blind, they need more of the adaptive technology, the magnifiers that are electronic, or the new eyes, which is the telescopic magnifier.
So then once you decide what works best for them and their goals and so forth, then the next step is figuring out who's going to pay. How it's going to get paid for.
Who's going to get paid for.
Oh, goodness.
I know.
And
They've done GoFundMe pages for all of these devices.
Oh, really?
People have done that, or state facilities, the Doors, Delaware. Every state has a division for visually impaired. So Delaware, Virginia, Maryland, all of them have it.
And locally, MAC has Bayside, Bay Area Center for Independent Living, that has various devices. Not those, but they have several other things that could be helpful, and they'll help find funding too. So it's all good news, because one statistic we forgot to mention is less than 5% of people with vision problems actually use adaptive equipment.
I know, and that's sad, because it definitely, thanks to like programs like this, or we put out health screenings we go to. We talk to all the doctors, ophthalmologists and optometrists who know about low vision already. We try to make it easy for them to refer their patients. They're seeing 50 patients a day, and they just need a brochure. We put magnifiers in their office. So they're very helpful when it comes time as well to need the service.
Well, I guess the first step is we have to get people to the eye doctor.
Yes.
And that tends to fall to the bottom of the priority list when you have medical problems as well. But just getting the annual eye exam, and then getting them to you or whichever resource, and then finding a way to pay for it, I guess, is the next obstacle.
Right.
So
we do take Medicare for patients for routine exams. Most eye doctors do. They may have to pay a copay for the refraction. There is separate eye care online that you can get called VSP, and you can actually purchase that yourself. I know the hospital has it as their group, but you can actually purchase that yourself. And it's very inexpensive, so that could get them either a $0 copay or a $10 copay to come in for their eye exams.
okay. Well, lots of really important information and helpful. And anything else you want to summarize?
You're absolutely, the best way to end this was to make sure that they go to their eye doctor. Even if it's a routine, like they get their teeth cleaned routinely, yearly, and they have not having any visual problems, it could pick up on some things that were early, where you can get vitamin supplementation to help you with macular degeneration, or get pressure drops to help you with glaucoma. So prevention is the key. I think that's the best way.
Glaucoma is a big one, getting those pressures checked, and especially if certain
symptoms.
Certain ethnic groups and such are higher risk, and it runs in families, so just get your eyes checked and be on the safe side. So thank you so much for coming in today
Thank you for having me.
and showing us your devices, and we have all this here locally where people can access that information and options for such.
Absolutely. We'd love to have them. They can call anytime. I have 2 direct staffs that work closely with low vision, that we try to see people even if they don't have an appointment. We try to at least go over the information at the office and then get them scheduled in as soon as we can.
Well, very good. And we'll put some websites at the end of the program that you recommended. Some just general information about low vision conditions, and others about that DOORS program you mentioned.
Correct.
Through the state of Maryland.
Right.
And then MAC is a great resource as well. So we'll put all those websites up at the end of the program. And thank you again for being with us.
Great. Thank you for having me.
And thank you for joining us for this edition of Focus on Health here on PAC 14.